And first of all, Dr. Beth King, who is also a wonderful colleague and friend whom I work with on the Cape V grant, the Caring-Based Academic Partnerships in Excellence, Veteran RNs in Primary Care. And this program is making a significant difference in primary care and also supporting our veterans who are interested in fulfilling a dream of theirs, which is to become a professional nurse. So welcome to you, Dr. Beth King, who is an associate professor. And also Dr. Joy Longo, who is the Assistant Dean of Undergraduate Programs at the FAU CE College of Nursing, Christine E. Lynn College of Nursing. And Joy was one of my, I believe in the second class of PhD students that I was privileged to teach at the college. And I am just so overjoyed and appreciate all the wonderful leadership that she provides in the undergraduate program. So welcome both Dr. King and Dr. Longo to our Circle of Caring.
Well, thanks everyone who's joined us this afternoon. We know it's been sort of a long day with all these meetings. So Joy and I appreciate having you join us. But today we're really going to talk about measurement of caring or evaluation of caring, which both Joy and I have a passion about. I'll just tell you my passion about it. My original dissertation was in higher education, but and I lived in Iowa at the time, but my dissertation was on measuring outcomes in nursing education. So and that was in 1991. And I really didn't have a mentor in Iowa for that, but I'm a psych person. So caring really is integral to my profession and practice. And so caring is really a component of psychiatric nursing. They're so intertwined, you can hardly distinguish between the two. So I always felt that, we say all nurses are caring, or, we are grounded in caring. And yet at the time, I didn't think we measured it very well. Actually, we probably didn't even discuss it very well. So that's where my passion came from. How about you, Joy?
So I, like Beth, in my dissertation, was looking for a way to measure caring, and I'm actually going to talk about it within our presentation. But I like to think a lot about measurement. I think I have that quantitative brain, even though I might do some qualitative research. Once I have an idea, I want to determine how do we measure that. So I'm excited to do this presentation today.
Yeah. So, we do have a little PowerPoint, only about 10 slides. Because we really want it to be discussion based and to look at what we're currently doing here at FAU in our own courses, just talk with each other about it. So I'm going to pull that up if that's okay. So I get this up. Where'd my slides go? Oh, here they are. I don't have it on the right slide here. Let me get this going. Now wait, before I do this, does everyone know everyone on the call today? We probably should have started off that way, Joy. Hold on, I'm going to start in a minute.
There's a canine on the call.
Yeah, maybe each of you, would you want to share your interest in measuring caring or evaluation of caring?
No.
Now, I was going to say Shirley's eating right now. So I was going to pick up. I'll start with someone else, Shirley. Howard, Raquel, how about you? I'm just going down my picture screen here. Interest in measuring caring or evaluating caring? I kind of equate the two, but.
Good afternoon. My name is Raquel Brown, and my interest, you said whether measuring or evaluating?
Yeah. How did you get interested in that?
I'm not hearing so well. Let me turn up my volume. Sorry. Can you ask the question again, Dr. King?
It's just if you could share with us your interest in measuring caring, or how, maybe you're just here to learn, but I know all of us do it. So measuring caring, evaluating caring?
Oh, well, I'm here to learn. However, I think regarding evaluating caring, I usually look at behaviors, sort of,
Okay,
attitudes,
yeah,
speech, stuff like that.
great. So we're gonna go into some of those. Thank you. Now, Howard, Howard actually teaches the caring course in measurement. Probably has a
Yeah.
different term.
Well, yeah. So in terms of the course, what the students are doing is they're developing a conceptual framework, or they're conceptualizing their phenomena within a caring framework. So my evaluation is on how well they are doing that. So I'm not looking at the practice of caring or caring behaviors as much as the conceptualization of caring, and how that they can use the concepts in caring theories to operationalize their research, conceptualize their phenomena within it, so they're building nursing science. And then when they're doing something qualitative, it's also where they're going to interpret the phenomena within the lens of a caring theory, and how well they're able to do that. So that's kind of like my thing about caring and evaluation. I was going to teach the measurement course in Caring 3. Remember we were talking about
Oh, that's
that?
right, yeah.
So I had selected the books for that. And one of the books I was going to use is the Watson book that has all of those tools in there.
Yep.
On how to measure caring. And I think that that's a really great resource. So,
It is.
So Pat's not, teaching that now. I'm hoping that you're going to be able to teach that soon.
We're gonna look, we're gonna look at those books too. Thank
Yeah.
you.
Okay.
I did a review of that book for the Journal of Human Caring.
Yeah. It's volume
Watson's
3.
book.
Now they're up to volume 3 on that. So it keeps on getting bigger.
Yeah. Tamara, I know Tamara just turned her picture off. Tamara, interest in measuring caring. How'd you get interested in it?
Yeah, I mean, I do have, this is my first time coming to the Learning Circle. I wasn't able to
Oh,
this semester because I was teaching
yeah,
in this time frame. So I'm really happy to be here, happy to interact with all of you. I must say that as Raquel mentioned, I mean, she's here to learn, I am too, but also as Howard talked about students, how they conceptualize the different frameworks, how they apply them. I'm really looking at too, how the students are able, they have their caring courses in the beginning, especially our DNP students, how they're able to bring that all together.
yeah.
They progress on throughout the program. I think that that's really, really important. And also different type of behaviors, how they apply it to their current practice and also future practice.
Great.
Looking
Yeah,
at
we're
all.
gonna look at those, especially in terms of our own tools that we use here. Yeah. Now, Shirley, would you want to share your interest in measuring caring? Oops, on mute, sorry. Can you unmute yourself?
Trying to, there we go.
Yeah.
I think we've been teaching caring and caring science for a long time. And I think whenever we're teaching anything, it's important for us to be able to measure the outcomes of that teaching so that we can develop new strategies, evaluate the strategies that we have and the learning that's actually occurring. So I'm very interested in how we teach caring science and how we measure the outcomes of those efforts. And of course, it's always important from a research perspective to be able to operationalize the concepts. So that really is what drives me.
Great,
In that area.
thank you. Michelle, I know you were on earlier, you had your picture face on earlier. Do you mind coming back?
I'm back. So for me, I am here to learn because I also was teaching in clinical last semester on Monday, so I never got to attend the learning circle. But I will say I also started in mental health, and I had an interest in that dynamic and how that works and how we interact with the patients. And even now when I transition into education more, how I can evaluate caring in the clinical setting. Because other places that I've been, that wasn't something that we did. And so I think for me, I'm interested to learn more, like how I can do that and how I can incorporate it more into what we're doing.
Yeah, great. Good, good. We're all gonna work on this together.
Yeah, excellent.
Yeah. How about Suzanne? I don't mean to put people on the spot, but Suzanne, measuring caring, have you given much thought to it or been
Oh.
involved in it?
Well, I am curious about this topic. As Dr. Gordon mentioned, the only way to really improve upon what we're currently doing, current strategies, is to measure the outcomes. And so I would love to hear from faculty who are teaching current caring science or doing research in that area in terms of what are the mechanisms that we can think about in terms of how it's having an impact on patient and patient interactions, interactions with your peers, in interdisciplinary teams, interprofessional teamwork across the board.
Yeah, great. And then we'll just jump to Terry, talking about interprofessional. Terry, how about tools of measurement? Do you want to briefly mention your simulation study?
Yeah, I guess that's where I would start, is that I first became interested. Well, first of all, Ann Boykin has always said everybody who's a faculty member at FAU is a caring scholar. And when I first came on faculty at FAU, I was an instructor in the professional learning lab at that time. So I became very interested about the fact that the Florida Board of Nursing was allowing so much of our students' experiences to be to be in the simulation setting, which nationally, simulation was supposed to be used for after the students had engaged, as just a way to reinforce, not in lieu of the patient relationship piece. And I was really interested about, could we measure or look at how could students live caring in the simulations that we were doing. But, and so that's where that came from.
Thank you. Let's see. How about Belinda? I don't know if Belinda's on, but I know Belinda as an RN has probably thought about caring and caring behaviors. I don't know if she's on.
Mhm.
She might be multitasking downstairs, you guys. So I'm going to jump to Deb. Deb, measurement of caring.
Did you ask me? I'm sorry.
I did, Deb.
Okay. I'm like trying to listen. Hi. For me, I've been with FAU since I was a student, and I've been very blessed to have wonderful faculty, including Dr. Terry Toohey and Dr. Dee Ray. I appreciate that. She's been a wonderful influence, and many more. So for me, it's always important that we live in caring through our presence and through our interaction with patients, their families, and of course it's essential when we're with students. And one thing, Dr. Boykin, who I was also blessed to have been hired when she was the dean, and I always remember that, as you said earlier, all persons are caring by virtue of being human. So even when it doesn't feel caring, you look for that and say, okay, you have to step back and reflect on what is it, what is caring, and what is the meaning, and what's important to that person, and how they're actually expressing that in either verbal or nonverbal ways. So for me, it's very important. And so I'm excited about this, because how do you measure it? And that's always an interesting aspect, as Dr. Gordon had said, when you're doing research and you want to think about, well, how do you measure this? And how do you talk about caring to others? Because often that don't know about caring, because often you have people say, well, I care, I provide care for patients. Well, we know that's much more. Caring science is much more than that. So I'm excited to learn from everybody. Thank you.
Yeah, great. Thank you.
Beth?
Yeah.
This is Dee.
Yes.
Dr. Turkel and I, over many years and with funded research,
Hello.
were able to evaluate.
Okay, I'm in another
Steve,
meeting.
one second.
Let me turn it.
I think if, Marlene, I think your mic might be open.
Later, you can, but I'll be in a meeting.
Oh, no. Oh, there, thanks. Sorry, Dee.
Oh, that's okay. We were able to receive funding, to begin to define caring in a broader sense, or in the way in which, current contemporary nurses were evaluating caring. So we initially got a major qualitative grant funded and studied, we actually, through that process, were able to generate a grounded theory related to relational caring. So then we reapplied for another grant to evaluate further with mixed methods. And so then we were able to develop questionnaires based on the themes that had been generated from the grounded theory. And then we went through the whole quantitative approach, to the measurement process. And so as Howard had mentioned, we are in that book by Watson, with measuring caring. And our questionnaires were both professional and patient oriented. And of course, we had to adjust them by virtue of the research methodology, quantitative approach. And then, so we were able to move from a questionnaire, I think initially, of about 45 questions to 15, which, that's generally what people will respond to. So we were able to measure caring in that context. And so I feel, we went through almost a decade of that process, with both mixed methods. So.
Dee, I was going to have you go last because I knew you have such an expertise in this field. So I was going to have you present last, but I'm glad you jumped in. Thank you.
Well, thank you. Thank you for
I had you
butting into your process.
Okay, let's see. How about Elizabeth? Where is it? I saw Elizabeth on here.
Hello, good afternoon.
Hi, there you are, Elizabeth. Yeah, how are you?
I'm fine.
How about
I'm
measuring?
at home with my baby, so you may just hear her make sounds once in a while. Say
Great.
hello to everybody. Say
Hello.
hello. So good afternoon, everybody. I've been a product of this school, and like from my very first semester, I've been introduced to caring, and I've been to caring conference a couple of times. And part of my dissertation, I was using Roche's 6Cs to see how it can be intentionally included in research work. How researchers can intentionally include Roche's 6Cs in their research process, because oftentimes when we use Roche's 6Cs, it's like in clinicals, not intentionally in the place of caring. So that's one of the things that I really want to work on going forward, and also try as much as possible to be intentional in allowing students to consciously practice using caring mentality and using caring theories.
Oh, good, Elizabeth. You're going to help us. We're going to talk about that later today. I mean,
Okay,
not today, like shortly. Yeah, great. Who else? Anybody else? Let's see. Dean George.
Hey, Beth. Hey, everyone.
Interest in measuring caring.
Yeah, I'm looking forward to today's session. One thing that I'm currently working on with our new postdoc, Dr. Data, if you haven't had a chance to meet him, hopefully you will soon, is we're working together on a paper about caring data science. So as we think of the intersection between caring science and data science, and how the healthcare field is really exploding in terms of using data science. And if you think of the importance of data science, you have to think back of measurement, of course.
Yeah.
Right? How was the data collected and measured? And so we're very interested in looking at data science through a caring theory lens, because we know that most data science see data as just numbers and data points. but we want to make sure that we add a new spin or set of directives to data scientists so that they can incorporate the 6 C's into the work of data science, to remember that there are stories behind just data points, and that in many cases in healthcare, there are people behind each set of data points. So I'm here to learn and hear from all of you, including Joy and what you have to say, Beth.
Thank you. And I think I'm afraid I'm going to mispronounce this, but Dr. DeBarshi, help me say your name correctly. Oops, I think you might be on mute. Are you?
Yes, thank you. The Bossy data, your pronunciation is good. Yes, thank you.
Sit here and sweat about that. So glad you joined us because we need your expertise too. Who else hasn't spoken? Anne, I'm saving you, so give me a minute. Armel and Marlene and Andra. Anybody want to share about their interest in measuring? Please, Armel.
Hi, hello.
Hi.
Hi, good afternoon. So, okay, so I'm very interested in caring. In fact, last issue of Sigma I3, we focus our theories of caring with Dr. Boykin and Shana Hofer there. And our next issue will be continuing the caring as well with Dr. Laxine and Dr. Lear. And I will give you the tips for our next issue of our Sigma I3. But for me, I'd like to see how we measure caring in the practice setting.
Yes.
Especially when consumer perspective of caring for the caring nurses, and how they perceive nurses in different practice setting, like even in education or in community nurse leaders, how they are perceived as caring, and how can we incentivize caring there, not only to promote the profession, but also how to extend beyond also the classroom and in our community setting.
Great.
Everybody cares for each other and our neighbors or something like that.
Yeah.
So I'm interested to how to measure that.
Oh, good. Wonderful. Thank you. How about Marlene?
Okay, so one of the things that I do is in all my classes, I try to teach or incorporate some type of caring assignment. So one of the things I've done is kind of evaluate how students use caring in their practice and their interaction with other patients, or how do they understand it when they're interacting with patients. So that's always important to me. And then the next thing is learning for myself, how can I intentionally care and use caring in my practice. So it's more of an evaluation process for me than actually measuring care.
Okay, thank you. Let's see, and Andrew's on the phone, so I'm not, and she may be driving. I don't know.
Yes, can you hear me?
Are you okay? Yeah.
Can you hear me? Okay.
Yes.
I finally gave up on my 65-degree office and headed home to work for the afternoon. But I wanted to be able to join you guys. So I was fortunate to have gotten my PhD from the University of Colorado under the influence of Jean Watson. And so, had the exposure to her book with the measurement of caring, those different tools. And then I have a little bit of experience in revision of instruments, specifically measuring human connection. That's linked to therapeutic alliance between caregivers and professional caregivers and patients. But I think what intrigues me about this discussion is being tasked with leading the graduate program in learning and getting up to speed on competency-based education, and really trying, as our programs are structured around caring science, how do we measure that in our students? And so I look forward to hearing that as I'm learning as well, and hopefully can help bring that forward as we start to think about how we revise our curriculums and evaluation tools.
Yeah, thank you. So I think everyone but Anne might have shared with us how they first were interested in measurement or evaluation of caring. Good person to end with.
Well, I've been interested in caring and the evaluation and knowing of caring forever. I think from an educational standpoint, using Simone's 6 C's and coming to understand how and measuring how do we as faculty in studying with students live caring uniquely? How do we live, the professionalization of caring, as Roach would say, uniquely in practice, and then understand how that is lived differently with those who are entrusted to our care. So that, to me, that kind of leads to even justice making and doing the right thing and being there in a right way. So that's always been really important to me. And then Savina and I, of course, have done a lot of practice research where we're interested and evaluated how is caring lived uniquely among different health professionals, but how is it specifically lived uniquely in nursing so that we can language the beauty of caring in nursing. And we've called some of our outcomes of our evaluation outcomes, but I'm much more focused on the notion, as I think Savina is, on the values experienced. What are the values experienced by being in this relationship? So I'm even interested in how the architectural students used to come to the college and study caring from a structural standpoint. How does our college breathe caring? So I have a lot of different dimensions of interest, and I'm really grateful for all of you being here and look forward to talking more about this. Thank you.
We're going to. So we're just going to pull up a few slides, not too many, because we really want it to be discussion oriented. So I'm going to share my, Joy, is that okay? Ready to start? Sure. Thanks for sharing, everyone. I know I really put you on the spot. So appreciate that. Let's get this going. Here it is. Is it up? Here we go. So, what's really interesting, we know that caring-based evaluations is critical to our curriculum, and it really is becoming more critical to almost all nursing education programs. We've really, I think all of us have, and scholars of nursing have embraced caring as a core value in nursing and a central concept to nursing education. We all know Leininger was one of the first persons to have identified caring as the essence of nursing. I was a little, I think many other people were doing it at the same time, but she clearly identified that. And now the AACN, the Essentials, is talking about caring. And Joy, I asked Joy to talk about this group of slides because it all relates to the Essentials. So I'm going to turn this over to Joy for a minute. And Joy, I'll just push the slides if you don't mind. Tell me.
Sure.
Yeah.
So as we had discussed this morning in our faculty meeting, and as we've been discussing probably for the past 6 months, AACN has new essentials coming out. And I think one of the things that we all noticed when the first draft was published, that caring was really central to the essentials. And one of the things when we think about measurement is we're really being called to look at competency-based education, and moving towards that, there's a focus on evaluation. So how are we actually going to measure these competencies? So Dr. King, and I will give her credit, looked through the essentials, and she pulled out 2 out of the 10 that she thought, where she saw caring really come out. And we had a discussion prior to this about all of the essentials. And I think we see ideas of caring in some of the other domains or the other essentials, but maybe not see the word of caring. So these 2 that we're going to focus on now, caring is very prominent in the term caring. But if you look at the other essentials, the ideas of caring and those core competencies, or maybe those core concepts of caring, are embedded if you really look. So the first essential is foundational elements.
Well, let me keep going here. I'm going to get up here for you.
No, I think the first slide, that's what I was
Oh, first
talking
slide. Okay, sorry. There you go.
That's okay. So the first domain was foundational elements, nursing as a discipline. So just some key points that were brought out here. Speaking of Nightingale, she didn't use the word caring explicitly, but there's a concept of caring and a commitment to others were evident within her actions, and that's credited to Dunphy. The term concept of caring was found. It's also described as defining attribute of the nursing discipline. And finally, there's five concepts that emerged defining the discipline: human wholeness, health, healing, and well-being, environment, health, relationships, and caring.
So Joy, that was found under, the introduction, where it wasn't specifically in a domain, but it was under the total introduction of the essentials.
Oh, okay.
I'm sorry. It's throughout though. Yeah.
Okay. All right. So there are some key concepts or featured concepts within the domains, and one is compassionate care, defined as compassionate care is interrelated with other concepts such as caring, empathy, and respect. I don't know, Dr. King, if you had anything, I know you had picked that out.
I think those really, when you guys look at that, you think, I automatically think of Mayer and Roach, because their concepts sort of interrelate with that language. So the languaging is there, which the language had been missing a little bit in some of the previous documents.
And then looking at all of the 10, I'm sorry, Dr. King, now I see what you're saying. Okay, so the two that, again, caring was most evident by terminology, not that it's not there by concept, was person-centered care and professionalism. So then focusing on person-centered care, some of the language there, if you look at 2.1, engage with the individual and establishing a caring relationship. And then you can go on.
So I always think this one's interesting. So, the left-hand column is undergrad, the right-hand column is advanced practice. But I look at the language and so it says demonstrate qualities of empathy. Well, we might all have different definitions of that and what we should measure in that aspect. Demonstrate compassionate care. Again, I always think, how are we going to do that in order to measure it and say this is an outcome, as well as that mutual respect? That's the undergrad. And then the advanced level is promoting caring relationships to effect positive outcomes. So I'm like looking at that thinking, oh gosh. And then fostering caring relationships. We have to actually say how we are going to accomplish this goal. So I think it might be a little interesting.
And then domain 9, which is professionalism. If you look at the contextual statement in here, again, the language of Roach and Meyerhoff is very evident with compassion, courage, humility, advocacy, and caring. So again, I think if you looked at the other domains, you would see this caring context as well in that. So now our next job is thinking about how are we going to measure this in our students? And that's really the focus that we're going to look at now. Going to the glossary in the essentials, there were 3 terms that again had to do with care. Care being a focused attention on and when possible, engagement with a patient to determine a person's particular needs and use of clinical judgment to meet those needs. There's also the definition of care outcomes as endpoints of care, substantial changes in health condition of a patient, changes in patient behavior caused by medical interventions. Given these definitions, outcomes related to clinical practice are any change that resulted from healthcare, and then caring relationship, where caring constitutes the essence of what it is to be human, having a profound effect on well-being and recovery, being at ease, and being healed. When hospitality is received, the patients feel connected, they begin to trust, and their healing begins.
Interesting definition for me, but we'll keep going.
Beth, just excuse me for interrupting, but can you go back one where Joy just was? Oh, right here, care. I think that care outcome strikes me as how far we have to go.
Yes.
Yeah.
We've got a long way to go.
And I actually tried to,
These
I was
definitions
in
are cringeworthy.
I looked at, tried to find Harris, they quote Harris 1991. I couldn't find her citation in the reference section. Maybe someone else can find it in the essentials, but I was interested in that too. I know.
So, Anne, based on your comment, this is Terry, I think it's important to look at your article with Savita on outcomes revisited with respect to that point. You think that that would be relevant to share?
I think it would be relevant, but yeah, and I think there's lots of other things. It's just the language again,
Yep.
you know.
Mhm. So we're going to keep going. So the essentials clearly has outlined caring as a concept that is dear to our hearts and what we practice. But the question is, how are we measuring it? And it's a difficult concept to measure and evaluate. And there's direct and indirect measures, quantitative and qualitative. And what I think one of the best resources that is out there are these measurement textbooks that I think, when was the first? I don't have the first one listed there.
Yeah.
I have the second edition. First edition came out when? Do you know, Dee?
This is the third edition.
That's the
on-
third.
on that, yeah.
I want to say about 2001, but I might be wrong.
Let's
But
see. This one also was like Sitzman.
That's that just came out 2019, right?
It was in the early 2000s when the first edition came out.
Yeah, okay.
And I'll get this third one here.
This is the current, the newest one right here, this one.
Yeah.
Yeah.
2019 for this one.
Yeah. So I would encourage all of us to contact our Springer representative and see if we can get a complimentary ebook for that. Just as we have the holistic textbook, we should all have this one in our systems to begin to look at. Oh, and then John Nelson has that one there, it came out in 2000, Measuring Caring International Research. This one, I have that textbook, but it is really focused on Watson and the Caritas processes, I think. There was a study, these are some of the caring tools that were identified, quantitative caring tools that were identified by Beck in 1999. We're still using these today. I'm not sure, can you see them very well? Caring behavior assessment, caring behavior inventory, caring dimension inventory, holistic caring inventory, caring satisfaction, caring ability, caring attributes, client perception, caring behavior checklist, caring behaviors of nurses scale. So we've been looking at this a lot. And Dr. Newman actually, I think it probably was about 2 years ago, compiled an Excel sheet of all the caring tools that were in full description. And that was housed somewhere, but I'm not sure where, but I will send it to everyone. We'll get that posted so everyone can look at it again. It was pretty detailed. I do like how Beck did this. It was real easy. You know, the instrument, the type, number of items, how long it took to take the tool. The only thing missing are the authors, which I thought was a little different, but it's just a sample of some of the tools that are out there. Briefly, Joy and I were just going to talk about our two studies. This one was specifically, Dr. France and myself did this. We were looking at, our hypothesis was a nursing program study grounded in a theoretical perspective of caring science will significantly improve a student's ability to care as measured by the caring ability inventory. And we chose that tool because it was built on Mayeroff's constructs 3, knowing, courage, and patience. So we thought that fit well with our philosophy and our curriculum here. But over 4 years, we didn't really have very significant results. We tested the undergrad students upon admission and then upon graduation. And knowing the means improved over 4 years. In 2016, we had significant results, but not in the direction hypothesized. Went the other way, as did courage in 2013. And patience, there were no significant changes upon admission and graduation. So, you know, we actually thought about this and we're in the process. We thought maybe that tool wasn't measuring some of the constructs that we think are important. So we're going to be looking further at that, the caring ability tool. I think that tool was developed in the early 1990s by Nakongo. And Joy, do you want to talk about your study?
Sure. So this actually goes back to my dissertation, and those of you that were here at that time know that I was interested in studying horizontal violence or bullying among nurses, because at that time I truly thought that how nurses felt about the work environment and how they were treated could impact patient care. I think that's even more relevant today. We know the stress nurses are under with COVID, and we're starting to see attention paid to that. You know, what is the effect on patient care? So in my study, I had measures of horizontal violence, and one of my committee members very astutely said, if you're going to look at horizontal violence, you need to look at caring. So I looked at instruments that existed that could measure caring within a work environment. And what I came across were two instruments by Hughes. They were in the Watson book. They actually were measures of faculty caring in a school of nursing and peer caring in a school of nursing. So with Hughes' permission, I revised the tool to measure manager caring and peer caring, meaning a staff nurse, how the manager cared for a staff nurse and how peers cared for a staff nurse. And within my study, I also looked at intent to leave, both intent to leave a job and intent to leave nursing. And what I found was that if managers were not caring, then nurses would consider leaving a job, which makes sense. You can go to another unit, you can go to another hospital. But if peers were not caring towards each other, the nurses would consider leaving nursing. So that was pretty significant. That was actually the significance in my study, finding that. But when I look back now, and we're talking about measuring in education, those tools are really relevant now in, again, converting back to Hughes's original intent of looking at faculty caring as well as students caring for each other. How do students support each other? So that's just an idea of something as we're looking at within our own program of measuring caring, that is a possibility.
Yeah, thank you. So when we think about measuring caring, oftentimes if you look at the tool, they're measuring one of these 5 aspects. They're either looking at human trait, moral imperative, affect, interpersonal interaction, or therapeutic intervention. They often look at a component of those. So let's look at us. So, you know, here at the College of Nursing, all of our syllabi are organized around Roach's 6 C's. And under each one, it tells us what the outcome is that we want to achieve based on that, attribute and the course of study or the program of course that the syllabus is in. So we do look at that. And then we also look at the assignments in terms of how do we measure the concept of caring, looking at the grading rubrics for that assignment. So if we had a lot of time, I would have us pull up our syllabuses and look at them and look at the 6 C's that are the language or the sub-objectives that are identified in the course, and then see how we're measuring those. Now, we're going to look at the clinical course. It might be a little bit more challenging. Hopefully in our didactic courses, we might be measuring them through exam. But through some of the assignments, we also should be measuring the outcomes of caring. But I encourage each of us to, in fact, I just looked at mine today to see whether I actually was measuring caring the way I wanted to be measuring caring in the assignments. And I probably need to do a little adjustment on mine in terms of the language of it and what I'm evaluating. I'm going to keep going here. So we also, Joy and I also looked at our clinical evaluation tools that we're using, both at the undergrad and grad level. And Joy's going to talk about the undergrad.
So this is an example of one of the areas on the undergrad evaluation tool. And those of you that teach an undergrad program are very familiar with this. And the tool itself is looking at several clinical competencies, one being caring. And one of the things that Beth and I discussed, if you looked at the criteria that's used to measure the caring, does it encompass everything that we define as caring? Items that it looks at are things like caring behaviors, providing care in a safe and timely manner, answering call lights, making sure the patient is assessed for pain, looking at the patient holistically, identifying cultural and spiritual values, beliefs, and attitudes related to client care. So one of the things that is a challenge, and I know those of you who have used the tool, since I've started in this position, I've heard this discussion a lot. We identify behaviors, but when it comes down to the actual measurement, what does that mean? It's really open for almost a subjective evaluation because we don't bring it down to a measure. And I see Raquel shaking her head because I know she's used this tool. So one area that I think we do need to look at is, not that we're not saying this could be evaluated qualitatively, but at the end, we are asking faculty to come up with a sum of what this caring value. And there's really, right now, as a tool is laid out, we don't have that ability to do that.
So Joy, even looking at that, it says physiological, spiritual, cultural, and psychosocial that identifies needs holistically. So how are they evaluating? Is that through the care plan or what's that through?
Why don't we have one of the clinical faculty, Michelle, use the tool for the first time last semester, or Kelly's used the tool? Because I've heard different things. Armil is very familiar with the tool.
Yeah, I think I agree with Dr. Longo. The language is explicit in terms of our objectives, in terms of and it could be interpreted subjectively by the faculty, but in terms of measuring it really by numbers, like we didn't have a tool in the clinical that would bring, oh God, the students showed caring through her or through her gestures, language that she used during patient interactions, when she gives medications that she explains. Well, we need to have a certain language that we can check, like a Likert scale, most likely, whatever, number one, then we can measure it in terms of it. But I know it's dynamic, but it could be a good start for us, I think, to quantify it.
I agree with you, Armel, because what we want to do is teach the students the caring behaviors that we would hope that would come out of this, or that would demonstrate caring. And yet, and as we all know, we like, if I'm a student, I want to know exactly what behaviors you might consider caring as the instructor. And it's one way to teach them and then evaluate it. Now, Joy, I'm going to go to that next slide. You have that other slide on the tool. Is that okay?
Yes. So, So also within the tool, there are critical elements that students must demonstrate in order to be successful in the clinical portion of the course. And some of these elements are, again, demonstrating and providing compassionate care, demonstrating authentic presence and caring behaviors. And those of us who have studied caring may have a very clear concept of what these mean. But again, one of the things we're lacking is helping faculty to, again, measure that. This is probably the question I get most from new faculty. And I'm going to be honest, I don't know if I have the best answer. How do we do that? And how are we actually measuring it? We have the language there. I'm not quite sure we have the measure yet.
Well, even with that, oh, sorry. Yeah.
Yep.
Is it appropriate to make a comment now or wait till the end? I'm not sure.
You can make it now, Dr. Boykin.
Well, I'm just thinking, looking at this, the language to me is saying that there is the way that you see it or I see it that defines what is compassionate care. I see it, I'm wondering, like in the practice research that we did, for example, the nurse in being, quote, evaluated, I use the language prized, but in prizing the work of the nurse, she brought or he brought their story of how they lived compassionate care, for example, from their world. So I just think that we need to be careful to think that there's one, our world, our answer is the answer to this. Do you know what I'm saying?
Uh-huh.
I hear you, Anne, but you know, how do we have to help the students while we have to help the students understand what compassionate care is and what the general literature says what caring behaviors are. Otherwise, we could have students being evaluated on faculty's perception of that differs with the students, and they could get scored lower. So the students need to understand what we're looking and evaluating them on, because it's a clinical evaluation tool. So it is a struggle. I use these tools. I'm going to go for it. Joy, is it okay if I move forward to the next one?
Yeah, so I'm thinking
I make a quick comment too, and that is, you know, there's going to be unique experiences between the nurse and the one nurse, but there's also going to be unique experiences within the practice settings themselves. So for example, in the earlier slide, when it says, you know, an example or a way to measure caring is if they answered the call lights. Well, not all practice settings will have call lights. So you can't develop an exhaustive list of what might be expressed as a caring behavior. So
now, these are our current tools that we use now.
No, I understand. Yeah. Okay. I understand. But I'm just saying it is a struggle, and it's a particular struggle for adjuncts faculty as well, who may not be as well versed as some of our full-time faculty are.
Yeah, I think it's a struggle for everyone, because sometimes you feel like you're being subjective, too subjective, I think.
Well, I think there is, especially in clinical, there's always an element of subjectivity in professional judgment.
Yeah, yeah.
But I think, I'm sorry.
Joy, go ahead.
To all 3 points, Dr. Boykin's point, Dr. Gordon, and yourself, you know, we in caring, we talk about coming to know others. So if it is a shared understanding, and whatever that understanding is, whatever the faculty goes in with the idea of what they want to see, it's making sure the student, they might have a different idea, but again, if there's going to be an evaluation, if there's going to be a grade, there has to be an understanding between the two. And maybe a behavior that the faculty at first did not deem as caring, if they speak with a student and the student, you know, explains what they were doing, what they were thinking, they may come to see that. So there's that room for mutual understanding, I guess, is what I'm thinking.
Yeah. Now I'm going to show you this one. This is
I'm wondering.
Joy, can I say one more thing about what Joy and Dr. Boykin were saying? I think that speaks to my understanding of competency-based education. And can really be 3 pieces to that. There can be self-evaluation, or 3 important things that keep being reiterated about it in all the different discussions. And that is self-evaluation, peer evaluation, and then faculty evaluation. And so to speak to Dr. Boykin's comment about not having one series of competencies, that we all may have some definitions that are the same, but we may have some that are different. I think it may be a place that we can put in some of these other aspects, perhaps going to what Joy was saying, sort of a self-evaluation. How are you carrying these out in your clinical practice? There may be a place for that there.
I think, Joy, Andrea, in both the undergrad and grad, the students do a self-evaluation based on the objectives of the course, for every course. So we do.
Can I say something?
Yeah. No.
I have this idea that as a college, maybe we can establish a committee that we can create language of caring that our students, our faculty, or even our colleagues can use, like a Bloom taxonomy. that when our students use this language in their reflection journals or in the discussion board, whatever it is, that signifies caring, that they have insights about caring. So maybe from a start that we will have adopt a language of caring that could be measured in clinical, that when our students mention that in their clinical evaluations, in their sub-evaluations, or even in our reflection journals or whatever it is, the measurement, that's caring, and then demonstrate it in the practice, the way the instructor or the professor or the clinical instructor sees them demonstrating it. Then there could be a lighted scale that we yes, I witness it, that she demonstrated or he demonstrated caring. Then from a start, maybe we can do we can have that conversation like a Bloom taxonomy about the caring language.
In terms, I'm sorry, this is Terry. In terms of language and caring, does anybody know whatever happened with Dr. Marilyn Parker's work on language and caring when she was working with engineering and she was trying to actually use the documentation in facilities? Okay.
So that is still the engineer, or the professor in engineering is still working on that. Charlotte and I talked to her a couple of years ago, but I don't think it's come to any full fruition.
May I say something?
Yeah,
you know, I'm looking at the current slide, and that is where my thought was going. Like, you have something demonstrate active listening. It to me, caring has to do about the response that you give to the other person, and are you paying attention? Are you responding to what the person said? How are you responding? So I think communication is a big way, a good way of demonstrating caring. And, like, if the person have made a request, how do you respond to it? Like, do you say, if, for example, if a person is in pain, do you say something like, I am, sorry to hear that you're having so much pain. How would you rate your pain on a scale of 1 to 10? So that way you get the how the patient is feeling, how severe is the pain, and then you would say, like, well, let me get you some medication for this. For me, that would be demonstrated. That would be one way a student could demonstrate caring. I don't know.
So Marlene, I agree. I mean, but I do think like these critical elements certainly need to be explained to the students how you actually are going to evaluate them. So if we say that they're going to provide compassionate care, we need to explain to the student what we expect from that. Because the faculty is going to, and I hear you, Anne, this faculty is an evaluation tool. So there are certain behaviors or indicators that they have to have in mind for measuring that. The student may have some others, but as an evaluation tool, I think it's a learning tool for both the student and the faculty. But we just use the language. We're not giving them any clear direction on it. I'm going to move forward because I know we're running, and I want us to talk a little bit more. This is the graduate. Oops. Sorry.
I was just going to say that a corollary to that as well, Beth, is if they're not demonstrating compassionate care, what is our improvement plan? How do we language an improvement plan?
Yeah, you're right, Shirley. Mm-hmm. Now look at this one. This is the graduate clinical evaluation tool for the Psych NP track. And it really was built off the FNP clinical evaluation tool. We just put in some language like the DSM, some different language that relates to psych. I have trouble reading it too. Let me see if I can enlarge it. I know there's a way to do it. Anybody help me? I don't know.
Try the magnifying glass at the bottom under the document.
Oh yeah, thank you. Thank you. That's what that is. Is that better? So when I looked at it, from day one, I looked at it, and I don't see the word care in there, except a caring approach in the first one.
Beth, you know what I don't see? I don't see nursing. I think this can be any provider of mental health.
Well, yeah, and this is the graduate clinical evaluation tool, FNPs, GMPs, this is the evaluation tool.
No, but isn't it based on the 6 Cs that you, because this, in their evaluation tool, they have to talk about how they accomplish each of the 6 Cs. You
Where do
know,
you
whether
see
it's
that?
competence, compassion, that when I listen to them and when I read it, that's what I'm looking for.
Do you see that language though, Marlene? Is that specifically broken down into, do you see the 6 Cs? I mean, so the student would understand that? I know.
Oh, you know, that is the I'm talking about the self-evaluation tool, the way the students evaluate themselves and how the faculty evaluate the student. When we do that evaluation, it's based on the 6 Cs. So, you know, like, I guess that's where I was going.
Yeah. Yeah, this is a clinical evaluation tool.
Oh, okay, yeah.
Yeah, I think that this is a deficit that we have identified for quite a few years, and we've had great intentions of both languaging it within the caring science perspective as well as leveling it, because we have one tool that's used across all clinical, even though there's 3 levels of clinical kind of in each of our concentration, or at least 2, and some of the cohorts that are not MP, or the concentrations that are not MP. So it's definitely a great area for improvement that we've identified, and then the pandemic hit us.
Well, no, there's no criticism here. It's just to help us.
Oh, no. Exactly. But now we have to do it because we have the motivation of accreditation now, and it's a really great time for this conversation so that we can best understand the path forward.
Yeah.
And you know, I'm wondering if we could implement the 6 Cs in that evaluation, the way we do it in, you know, the faculty student self-evaluation. You know, I think that might be an appropriate way to do it.
I agree, Marlene. And even in the undergrad here, I'm gonna, there were some questions. I'm just gonna get out of here so I can see people. How do I exit? Oh, stop sharing. I agree with all of what you're saying. I actually thought the undergrad clinical tool used to be organized under the 6 Cs. But when I look at the current tool, it is not. I mean, it actually would say compassion, and then it would have some things under each one. But I don't see that today. And I think even in the, well, we don't see it in the graduate evaluation tool either.
I think
we do see it in our didactic courses. You know, we have it very clear in the didactic courses. I just think we probably need to clean it up in our clinical courses, and then figure out how we're going to evaluate it, so that both the student and the faculty have a mutual understanding of what the expectation is, since it is an evaluation tool. What do you guys think? I mean, should we be measuring their caring behaviors, or I don't know?
I think we can measure caring by compartmentalizing it, or make it like by segment. What do you mean by caring in compassionate caring? How can we narrow it down in a language that we can understand both students and the faculty, and also the nurses out there on the unit, whatever it is. So based on the 6 Cs, we can further narrow it and make it more explicit. That is the language of caring. Maybe we can do like a Bloom's taxonomy. That's my thinking.
Like I'm thinking, for example, if you're being competent, then when you're doing, you know, under competence could list how are you doing your assessment when you meet the patient, when you're making that critical decision. You know, are you assessing, listening to the lungs, listening to the heart? If, like, for example, sometimes a patient comes in with pain, and the student will listen to the heart and to the lungs, but they won't assess that the patient has a pain in the hip. And it's like, you know, like I have to take a grade off of that, some points off of that. So, you know, that's part of competence. You know, you have to listen to the patient, and probably compassion also. Because, for example, if a patient is complaining of constipation and you don't address the constipation and ask them what's going on in their bowels, then you didn't, you know.
But here's my question, even for myself. Where in my evaluation tool do I clearly outline for the student what might be some essential, I don't know, outcomes or behaviors that I would want to see. Because otherwise it's me in my own head thinking, gosh, they didn't assess pain. I don't know, I struggle with it. Anybody else?
Beth,
Yeah.
I'm wondering, I think this is so much fun. I love this dialogue. I'm just wondering at the graduate level now.
Yeah.
Might it be possible to have the form of quote evaluation be narrative and where the student would present a nursing situation and then they would follow the 6 C's or whatever in dialoguing about that nursing situation, in a reflective way. To me, maybe we just need a different way to look at that. I don't know. I'm just thinking, but I really appreciate the conversation.
I think, and so I can just tell you what we tried this fall in the one course that we had, where we know that one of the outcomes we want a Psych MP to be able to do is do a psychiatric evaluation, right? So their outcome was they were given a patient and they had to interview the patient and record it, a video record it and submit the video recording along with the treatment plan, which I think FNPs could do the same thing, and that was one of their final tools that we evaluated for competency.
Mm-hmm.
So, Anne, while I hear you, the dialogue, the issue with some of the MP tracks is that, we want them to certainly have competence at each course at different levels. At the first course, it might be a different expectation than the last course.
So I think what Anne is saying, I think to some extent we do. For example, if I go into a clinical area and I observe a student do an assessment, then at the end, the student and I sit down together and I say, well, how do you think you did? And then I might point out, I would first of all say what went well. And then I would point out, something that maybe the student had missed. So we do engage in that dialogue, but perhaps is to ask the student to, what I hear Anne saying is ask the student, have the student review it. And then perhaps at the end, whatever I thought was missing, then I can verbalize that.
Yeah.
And we still have the checklist. I'm still checking everything. And I have the student tell me what they're doing and what they did, how they think they did. And if I think something was missing, then at the end, I might put that in.
Mm-hmm.
Is that what you were trying to say, Anne? Dr. Boykin?
Yes. Yeah. I mean, I know it's really complex. Yeah.
It is complex, isn't it? But our program, we've been here for 30 years. I keep thinking we should probably have this down, but I don't know that we do.
We're just asking new questions.
Oh, maybe that's it, Shirley.
And I've been reading a book called Emergent Teaching.
Yep.
And are you familiar with that book?
Yeah.
And it really challenges you to take a hard look at how we're writing objectives. And based on how we're writing objectives, how are we determining if objectives were met? And just, as an example, one of the ideas from this book is that we look at student learning from the perspective of whether or not it encourages personal choices and responses. Which certainly fits in with our philosophy of, caring and being mutually respectful of one another, and whether or not students are being creative in their
Really,
approach.
that book guided our summer academies from the beginning.
Oh, did it?
Yes. Yeah.
Yeah, it's a good fit with your theory, especially the part about learning is always self-reflective.
Mm-hmm.
Every opportunity to learn as an opportunity to
I
learn
think
about
we
yourself.
incorporate a lot of those in all of our courses. You know, most of them have self-reflective journals to some extent. A lot of them have presentation of a nursing situation with a,
Mhm.
you know, treat whatever focus it is on. But I always worry a little bit about the subjectivity and wondering if the student really knows what the expectation is, whether we're too broad in our descriptors.
Well, and we do struggle with right and wrong when we're open to possibilities. You know, that's a perennial struggle for us.
Now, there is some right and wrong in nursing.
Yeah, there is. But there's also room for possibilities.
Gray zones. You know,
Well,
one thing we also should, one other thing Joy and I talked about that I bet all of us have heard when maybe we give a low grade and then we're not demonstrating caring behaviors. The student comes back at us, not at us, but, you know, says to us, well, that's not very caring, or I don't know what other words we've all heard. You know, what do you guys think? Anybody had that experience?
A lot.
Causes self-reflection on my part every time.
Yeah. I had shared way back when I was in the nurse educator concentration. I had Marilyn Parker for one of the education courses, and she brought in Savina, who actually spoke to us about students who were unsuccessful and was it caring if they were unsuccessful. And they continued on. And she said it was caring because there are certain expectations that we have of students to show that they're safe and competent. And if they aren't demonstrating that competence, then, we have to, unfortunately, they're not going to be successful. And I take that with me a lot. I think about that a lot because, of course, we all want our students to be successful. I know everyone goes out of their way to help students be successful. And sometimes, no matter what we do, it's up to the student to carry some of it. And, like I said, I know we all go out of the way to help students, but sometimes they're not successful.
That's actually a common question that I get asked when I'm at different conferences around and they hear I'm from FAU and they go, oh, you're that caring place. And then there's the question, how do you feel students? If you're grounded in caring, how do you feel students? Yeah. So it's a common question, but competence certainly is important. The idea that we care not only for students, but we care for the profession, we care for our patients, we care for, our care occurs on multiple levels.
Right.
And how we are in relationship to students when they're unsuccessful is another way in which we live caring. I had one student one time that went all the way through to the provost's office because he was eventually dismissed from the program. And he asked me to come along for moral support when he met with the provost. And then after the meeting, the provost asked me to stay for a moment. He goes, well, this was a first for me. A student who you are kicking out of your program has you there as moral support. And of course, in our conversation with him, the student said, Dr. Gordon's my biggest fan. And I am one of his biggest fans, but he was not successful in the program. It wasn't a good time in his life to continue. So it's that, how we live it is a big part of it too.
And Shirley, it's like you're saying, it's providing them the opportunity to grow, not that they can't in the future, but at that moment in time, going back to Roach's besides competence, as you said, it's the consciousness, what ought to be in this moment in time that we're responsible for.
Yep.
Yeah.
But I always reflect as a faculty, did I make clear to the student, did they understand what I expected, what I was going to evaluate them on? Because I just think sometimes, me too, I'm a little vague. I have it in my head, but I'm not sure I've shared it with the student. So it's a mutual understanding. And I don't think that our evaluation tools do that.
I remember I had a situation once where I had a student who was unsuccessful on an assignment and was very upset. And once I sat down with them and we looked at the assignment together, like a light bulb went on. And they're like, no wonder you gave me the grade you gave me. I just didn't get the assignment. But it was having that dialogue, and then they understood. So,
But don't you sometimes look at the assignment and say, gosh, I could have been more, I could have explained this better,
right.
you know?
Yeah. And so anyway.
So evaluation, measurement are fun to think about, challenging. And I think, you know, the new essentials will give us some time and opportunity to do a little bit more, probably improve our way of evaluation, I think, and focus on it a little. We focused on teaching and learning a lot. But you know, I think the evaluation component could do a little work. What do you guys think?
Yeah. And I think a really important piece is helping new faculty. You know, we have some on the call when they come in and are given like the evaluation tool. How do we help them understand? We have a lot of adjuncts and they want to do their best. They want to be consistent, and we have to be clear about what our expectations are, or we can't help them. So
Joy, that's a good point, that consistency between us, you know, if you have 3 people teaching the clinical course, are we all being consistent?
No, another aspect of our evaluation tools, especially the ones that are, you know, almost like Likert, or they do it most of the time or whatever.
Yeah.
And you get a student gets an excellent score on day 3 or at midterm, then I've had students tell me, well, I'm done.
Yeah.
I've met all these objectives. I'm done.
It's because
So I
we
think-
haven't, I don't think we've not layered. What's the other word? Help me. Scaffold our tools. and
Scaffold or leveling.
Are leveling our expectations for the different courses. But you're right, Shirley. If they're able to get all 5s by midterm.
Where, yeah, they have nowhere to go for midterm except down. So that's not a good thing. Or so maybe we should be measuring some things at midterm and other things at final that are more comprehensive, or that, you know, that do build on one another.
one of the, and I'm not going to say this correctly, but I think one of the responses that you can give is developing competency in the tool. So it's showing that they're getting there. They're not quite there yet. But at midterm, if they're developing, that's a good thing.
You have that in the, you have like 5 levels in the undergraduate tool. And maybe we all need to be, you know, maybe we need to be consistent in our languaging of that. And even in our grading rubrics, maybe if we all use the same, the criteria, you know, that up top heading. I think sometimes I'm different than someone else, but maybe we could all, well, we could all look at that.
I'm also thinking that if things are situation specific, a student may get a 5 in week 3, but week 4 they may get a 3 because
they didn't
perform the same way at week 5 as they did in week 3.
Good point, Raquel. Yeah.
So I don't know.
But the tools themselves for faculty can be a little cumbersome, especially if you have to do that at the undergrad. I remember we did weekly ones. What do you guys think? So all of a sudden you're kind of checking.
But you know, Raquel has a really good point, because on that 4th week, they might have a more challenging patient. So to be safe at one level is okay for that patient until they learn further skills. And then the next week they might go back to the 4. And I think, again, helping the student understand that, you know, they're learning along the way. They're not going to get to midterm and know everything.
But Joy, that might speak to our teaching aspect, where we want the certain students to have a certain level of patient for the first 4 weeks and get really good at it. And then level them up to the next level of patient if we're able to do that.
Right.
Or even begin to look at how we're presenting didactic content over the course of the semester. And if you are evaluating weekly, you know, focusing on a specific aspect in that particular week, as opposed to those huge comprehensive.
That's an interesting thought too. Yeah. this week, can you demonstrate
Right.
cardiac
So that it
assessment?
would align more closely with what they're learning in the classroom. Now, you can't always assign based on that, but certainly there are a lot of things that they're learning that apply to every patient.
Yeah, takes a lot of
So-
time, doesn't it, you guys? And thought? Oh my
It
God.
does, but I like your idea about time, Beth, in terms of how long are these evaluations, because I suspect the longer they are,
I know.
the less thought and effort are put into them.
Yep.
Because especially if you've got a large number of students.
Yeah. Now, the good news that, that's decreased clinically over the last couple of years.
Yes.
To 8
yes.
typically, and that's, but when it was 12, it was, or if you had 3 groups of 12, that's a lot of students.
I'm wondering too, for clinical, if we couldn't add an aspect of the patient perspective.
Oh, I've always wanted to.
Yeah, they just added those, questions related
Yeah.
to JCO. I mean,
Dr. Gordon, I always ask that to my students. I told them that part of your grading, I ask your nurse how you are performing and how you are relating to the patients. I also interviewed patients, how they are being taken care of by our students. So I say it's not only me that or your perspective that counts in my evaluation, because I'm not be there all the time to see you. So I ask those who you are interacted with. So I always do that in the beginning.
well, and maybe that needs to be like one of the vital signs, like we assess pain, assess caring, with their perception of being cared for.
Or should we have the students give the patients they care for that, there's a couple of tools that patients fill out about their level of care that they've received.
I presented several of those one time during Nurses Week at Jupiter Hospital, and the nurses were really frightened about that idea.
Yeah, but we could have our students do it because we need to have some control over that. I think it would give them an interesting perspective of what the patient thought.
Yeah.
Yeah.
It's not part of our formal assessment process right now, but it certainly could be.
Yeah.
Beth, Marion and I, in the questionnaires that we advanced, from research, and we had a patient tool, which does ask the patient, if I can pull it up here, maybe to give a couple of examples. It's called Relational Caring Questionnaire, and it's the patient form. And the other one was the professional or nurse form. And so this one asks the patient, for example, I'm treated with respect. And this happens when I'm a patient at this hospital. So then they have to, it's a Likert scale. So they respond to that. And then second one, I'm given care based on what is important to me. And that, of course, they respond. And then I take an active part in my own healthcare decisions. It's another one. And knowing the nurse knows what to do for me builds my trust in the nurse. And so in this particular one, it has 15 item questionnaire for the patient. And the one for the professional is a little bit longer. It's a 26 item questionnaire for the nurse. If he or she were to take this questionnaire. But I remember, Beth, and I was trying to think, when you and I, years ago with one of the AACN evaluations, I think at that time it was NLN, and Anne had, we were expecting the accreditors to come. And so we had to, our concern was this evaluative tool relative to caring. And so it was a quick act on our part in order to produce something, for this accreditation. And I don't know if you remember that too, Anne, but we built it on this more of an interpretive understanding. And when I'm listening to this discussion right now, there's a lot of interpretation going on here on the part of the educator, as well as the way in which the student might be responding to what was going on, or if you're observing the relationship itself, it is I mean, you talked earlier about subjective interpretation, but it is subjective, you know, and caring to a large extent, even when we assess ourselves, is an interpretive and reflective process, you know. So we did pass that accreditation, and that was a long, I could say practically 20 years ago, when probably accreditors weren't even looking at it at a concept of evaluation relative to some kind of hermeneutic or interpretive mutual or some type of understanding, you know. So this is a challenge for us because we are a challenging College of Nursing, and you know, we have a different approach as I'm listening to this conversation. But I don't know if we could resurrect, what we did, you know, because I remember you and I were challenged by Dr. to create this tool, you know.
Pull that out. I know we're running out of time, you guys. So I really thank you for being here. Joy and I both appreciate it. It really, it is so much fun to think about. And, you know, oftentimes, you know, when you're doing our syllabuses and thinking up our, you know, our grading rubrics and all of that, you know, another set of eyes would certainly be wonderful, and to look at it and say, gosh, you didn't even put caring in there, Beth. I don't know. I just think we need to help each other in this arena. And always think about, you know, can the student understand what we're trying to help them learn?
And have humility when they don't. And while we're talking about evaluation, we need to carry this conversation into how we evaluate our clinical sites as well. Not today, but eventually.
Yeah, I know. And speaking of that, we all have our own self-evaluations due, don't we?
We do.
We do. Don't have it done. I actually haven't started.
No, I haven't got mine done either. Now there's some interpretation.
Does everyone understand why we're laughing at that? Our Mel's looking at us very soberly. We have to find things to support, you know, support what we do. Really, Joy,
we talk about authentic presence all the time, about one of the meanings of the central component of caring and nursing, right? Yes. You know, so I mean, this challenges us, you know, what is the meaning of this authentic presence or authenticity, especially also even in relationship to clinical environments, you know.
Well, and how do we teach that to students and have them demonstrate it to us?
Yes.
The patient is the one who's going to tell them.
And that goes along with, you know, the grading process, you know, when students challenge a teacher to say, well, you're not caring if you get a C or even a D, you know, but if you're looking at authenticity, you know, as a component and how we define it, it, you know, can free us from this feeling of guilt, you know. Right? So.
Joy, anything else?
No, but I'm just thinking, I was going to say one thing on authentic presence, and Dee, I'm glad you brought it up. I can't tell you how many times I've heard students in telling about a nursing situation, they use authentic presence like an intervention. I was authentically present, but then I don't know what that means. What did they learn from the situation by being authentically present? Like they stop and say, I was authentically present, but then I don't know what they gleaned out of being authentically present. I always struggled with that.
Well, it's the first semester. It's great they even knew the language.
Yeah, I give them that credit. Yes, absolutely. But then
semester, maybe third, you know, maybe a little more.
That's the scaffolding piece. I guess introduce the term and then understand what it actually.
Yeah.
I liked your concept before, Joy, when you said mutual understanding. That is crucial, I think.
It is. Even like in our tools, when we said demonstrate caring behaviors, well, which ones are we expecting them to demonstrate? I don't know. I can tell you, and Dee's heard this story before. Acute care nurses never demonstrated caring to me until I read her research, because they would never talk to my patients. they didn't want to talk to my psych patients. They just, you know, it's bothered me so much. But then I came to understand that their demonstration of caring was, you know, keeping the person alive. So, you know, I think we need to help students understand in this course, what might we expect to see?
Thinking, one time I have this experience at clinical, like with the ABI students. When we see authentic presence with the students, and one student commented to me, "Sir, I'm not comfortable talking to the patients yet. We don't have this practice in simulation, but we have to talk in what response we have to the patients if it's a difficult conversation." So I came up with the idea that during the post-conference, let's do a one-on-one with your peers. How do you respond in talking to such situations so you can be comfortable talking to the patient? Because if I grade them right there and then, I will not give them a high score, because even yourself, you're not comfortable talking to the patient. How can you be authentically present?
Right.
So I think we need to bridge that gap in their confidence.
And it's part, it is your confidence, because I have seen it at their immersion course.
That's true.
Where they don't have the confidence to talk to a patient.
I think some practicing or like persistence.
Yeah.
Yeah.
Well, we have a lot of work, don't you think?
Our jobs are
we could all
secure.
be employed for a couple more years. Just to get this done, or started or furthered. Anyway, anything else?
I also think instead of using all those terminologies, we need to like explain things out to the students. The reason why they say I'm authentically present is because we mention authentic presence every time. You need to be authentically present with your patient, and they'll just tell you I'm authentically present. So you can't say you're authentically present with your patient when your patient just wants you to listen. Keep quiet, just listen to me. Let me just cry at this point in time. So like when we try to like explain it out to them, and I think for the undergrad, it starts from the very first semester when we are just explaining all of these terminologies. This is how you do. And in the lab, do it with your mannequins. They are not mannequins, they are real human beings. Relate with yourselves respectfully. And when they're able to show that, by the time they get to clinicals, they're able to just express it freely.
Yeah, thank you. Anybody else? I know we're running a little over.
Thank you for doing this. This was fun.
It is fun, isn't it? Well, next time, maybe we could, like, I'd love to have some help on my clinical tool.
It's a good idea. Have somebody bring theirs forward and let's get some thoughts and comments. We don't understand it, then it's possible.
If we can't understand it, how could a student understand it, you know?
Right.
Well,
that'd be a great idea.
Dr. DeBarshi, any comments? Put him on the spot again here.
Yeah, I'm just listening. Your talk is very nice. And actually, we are trying to, Dr. George and I trying to build a course or a separate domain of data science where we can only think of caring field or medical health field. So trying to understand that Sister Roach's 6C with how it should be incorporated in a data science field of data science. Means in a data science to the technical person is like a data, like just coding, data, graphs, all those things, plots. But what is the story behind the data? How you understand all 6 component factor Sister Roach is described in the data science, the field of data science. So it's a very beginning stage, but we are writing a paper, and we also submitted the abstract to the I think the International Nursing Conference that will be this year in Edinburgh, in Scotland. So we got selected to present in person. So we'll see how it going, how it goes.
Yeah. Well, thank you. Well, I certainly would welcome us. I'll put a call out for people to help me work on my evaluation tool. Because it clear, I was shocked in retrospect when I look at it, and I'm not sure I see nursing or caring. Some of it's, I mean, this needs work.
Well, I had tried to break some of the things down instead of using that large tool. But because we have to use the same tool, I had to go back to that tool. So talking about respect to the patient, respect to your peers, respect for the instructor, talking to the patient. So I try to encourage the students that the mannequin is your patient. Sometimes I will be the voice of the mannequin. Sometimes their peers will be. However, they have to communicate with the mannequin like they would with someone in the hospital. So that's their patient.
It is. It's probably easier for some than others, maybe. I don't know.
Yes, it's not easy for all of them. Last semester, the group that I had last semester, they really enjoyed communicating, and I know they're the accelerated group, and they've had other experiences with college and different courses that gave them that kind of exposure.
Yeah.
But I did encourage them that this is your patient. It's fine to make jokes and have a good time when you're learning, but speak to your patient the way you would want. I tell them this could be you, it could be your mom, it could be your grandma, it could be your child. So that's how you're going to address this person, the way you would want to be respected and so on. And so I tried breaking the tool down in a simpler way with little things that they could understand. But yeah, it is challenging using that tool.
Hey, Raquel, I got to apologize. You have your hand up there? I didn't see it, so I apologize.
Yeah, sorry, that's been a long time. Let me take it down.
But I know I need to go to a meeting too. So thank you. Let's work on this together. Help each other.
Thank you.
Thank you.
All right.
Have a good afternoon.
Thanks for joining us.
All right.
Yeah,
Bye-bye.
thank you, everybody. Bye.